too. We are joined today on Healthy at Home with Komen, Florida, Dr. Martin Dietrich from Florida Cancer Specialists. Good morning, doctor.
Good morning. Thanks so much for having us today.
I really appreciate you taking the time to spend with us and talk about not only breast cancer care and what's happening in the world of metastatic breast cancer, but also just the landscape of COVID-19 in Central Florida. We were talking before we started. What I found really interesting is your increased use of telemedicine. You were saying that patients don't have to come and sit in your waiting room, and that you're able to then meet with them almost more conveniently. How are your patients, reacting to this need of now not having to come to your office?
Well, Josh, it really depends on the setting. There are obviously some visits that are still preferably happening in a face-to-face discussion when having difficult scan reviews, when we want to talk about different options, especially if we have difficult decisions to make. There's certain circumstances, I think the well visits that are currently taking place, results disclosures that have happened in the follow-up setting, we've transferred those completely into the telemedicine space, and I think both patients and the clinic benefit from the lack of waiting time, basically an on-demand almost kind of interaction that is actually quite efficient for both sides. I think it has been one of the few positive aspects of COVID, that we finally have an entry of technology into the patient interactions. So that certainly helps. Unfortunately, there's some visits where I still think it is necessary to have these face-to-face encounters, and we just have to work around the complexities of the COVID concerns right now to make them still happen in a safe and reasonable manner.
So let's talk about metastatic breast cancer. The stage 4, these patients have additional treatments and concerns. So, in this world, and I hate calling it the new world, but it's the current situation we're in with COVID-19. What special precautions with those who are living with MBC should be taking more so than others right now?
Right. So there's clearly a number of issues require a number of complexes. Obviously, the first one, and this is what we really know, and I think that there's a lot that we don't know where we kind of fill in our concerns, is the sensible measures of precaution and prevention. The difficult reduction of social interactions, social contacts to minimize the risk of exposure, the use of protective barriers, masks, gloves in the right setting, hand sanitizers, behavioral modification, face touching, and things that are very, very helpful. And I think that's probably where we have the best data. In the clinic setting, we're not nearly about how to prevent COVID as much as we can. I mean, in our clinic space and then also in the infusion areas, we've spaced out the individual infusion chairs, we've spaced out the appointments to minimize interactions between patients so that they're kept safer. I think that's very important. There's some institutions that have started screening every patient for an asymptomatic carrier status. Not sure that there's any data to support it, but I think the main approach for us has been to be cautious and make these visits as safe as possible. Unfortunately, with metastatic breast cancer, there's not a good chance to move this into a virtual space, and we kind of have an obligation to still deliver care. Now, you've mentioned that there has been a lot of progress, and I think this helps us in terms of selecting patients. Obviously, there is a concern about immunosuppression in the setting of COVID infections, and we have a number of new options, both for metastatic triple negative as well as metastatic HER2 positive breast cancers that have been approved, but actually are deliverable in an outpatient setting, in an ambulatory setting without infusions, and make it a lot safer for us to continue treating patients that are in need of treatment by expanding the armamentarium of options that we have to treat metastatic breast cancer. So there have been a number of approvals in the last couple of months, and I think they came just at the right time to help us navigate the difficulties of COVID-19.
So, whether you're, battling breast cancer or you're, have MBC, you're at home and your life is different. It's certainly not what you've been used to. how can people at home cope with this, limited interaction from outside world or their friends?
Right. Well, I think this is going to be a question to which I won't have a complete answer. We found that it's very helpful for patients to get more accustomed to the virtual world, to have social contacts either by FaceTime or similar online platforms that are helpful, or in family settings, face-to-face visits using social distancing practices that are still deemed to be safe, maybe outside, maybe with the proper physical distance to family members. I think it's incredibly important to maintain socially active and socially integrated whilst maintaining physical distancing. The fight for cancer is one that requires the full body and the full mind, and I don't know how you can maintain a level of sanity without having had that support system and those interactions that are so crucial in discussing things where you can reach out and ask for help and have that connectivity still maintained despite the difficult times. But it does require a great degree of flexibility and adjustment, because things are different and they will be for the foreseeable future. So it's not as easy as we thought in the beginning that we just sit this out for 2 weeks and the virus will go away. See, in certain parts of the country, the numbers are actually going up again. So some people call it the second wave. I still feel we're kind of in the middle of the first one. And until we have a vaccine or much less likely a more generalized immunity in the population, I do think this is going to be our new normal. So I would encourage everybody, including our older patients that are not as accustomed to technology, to really capitalize on the opportunities we have to reach out to family, to maintain these contacts and try to make the best of it. There's not in my opinion, not a good way yet that I have found to replace the physical hug of a good friend or a family member. But there's certainly opportunities to stay in contact, to not feel isolated, to not be alone with your worries and concerns, and still have a degree of outreach that is helpful for the difficult journey of cancer.
And we have a question that came in from Sean. Sean has been a longtime supporter, and she's a survivor. 3 years ago, she was diagnosed with HER2 positive and HER2 negative. She wants to know, is there any particular blood test that she should make sure she gets to monitor? And as well, is there any protocols she should be following specifically because of that?
So that would depend on the individual circumstance. A lot of patients that have HER2 positive breast cancer that are in good control are not on immunosuppressive therapies. They have when they have infusions, they're getting ongoing treatment. If they have completed treatment, it's a little bit of a different story. And I would feel more confident when you're mentioning a 3-year time frame, that it's reasonable to postpone some of the in-person visits and the follow-up scans, because it's typically a time frame after which HER2 positive breast cancer is much less likely to return. It's a very aggressive form of cancer, so if it were to return, it typically recurs earlier. If you're on ongoing maintenance treatment with HER2 targeting drugs, some of them are not immunosuppressants, so they wouldn't necessarily set you up medically for a higher risk of infection, but they could certainly, through the procedure of getting these drugs and having the exposure to medical facilities, raise a concern. And my feeling is that the rate of the concern about cancer in most parts is currently higher than the rate of COVID, and that with proper physical measures, the treatment should proceed as much as possible close to normality. We can do things like getting lab draws at outside labs, and maybe do a little bit more by telemedicine to reduce the visits. But I do think that if this is an ongoing treatment in remission, that I'd be encouraging to find ways of safely continuing this treatment, because one is a very real and present danger, and the other one is one that is certainly around us, but not necessarily in a way that should preclude us from attending to matters at hand.
That's really, really
I'm
helpful.
sure that answers the question. I don't have a lot of all the medical background, but it's certainly one where I think the story of being 3 years out in general typically proclaims that there has been a very good success story behind it, and I would not jeopardize that by being too worried about a virus concern in the setting of an aggressive cancer.
That was some helpful information. I'm sure that answered Sean's question. So, our immune systems are very key, and we need to make sure we take care of ourselves. Are there any recommendations that you have to boost our immune systems for patients with MBC?
Right. So this is a very interesting question, and the issue in general is the concern about a suppressive immune system, suppressed immune system, and the resulting bacterial infections, especially with chemotherapy. So that is a concern where we can give growth factors to maintain a white blood cell system. In terms of COVID, the concern is actually at the opposite end. The patients that get really sick from COVID are those where the immune system is mounting and able to mount an overwhelmingly strong immune response, almost like an autoimmune response that leads to these fulminant pulmonary infections and pneumonia-like pictures that are resulting in respiratory distress and intubation. So I'm not necessarily sure that boosting the immune system is going to be the way to go in terms of prevention of severe COVID-related complications. I would actually say that most of the therapies that we're testing currently are more in the immunosuppressive setting. We've just had a study about low-dose prednisone that seemed to be helpful. Obviously, there has been a lot of talk with questionable data about hydroxychloroquine and others. If anything, an immune system that is not overactive may actually be helpful. But again, I'm saying this with a great degree of uncertainty. So until we have a vaccine for any cancer patient, the best advice is to maintain discipline of the COVID marathon, to avoid exposure, to minimize your risk. And not only the risk of exposure, but also the risk of high dose exposure. We clearly know, and you see these tragic stories of young nurses in hospitals in New York on TV that have been getting tremendously ill from this. And we always wonder why that is. And I think it's become very clear that the repeat exposure to patients that are shedding high amount of viral load is responsible here. That this is not one exchange of viral particles, but repeated high dose viral titers that eventually lead to a more sickness and more complications. So there is a discipline that has to be maintained. I would not recommend general immune boosters. I shop at Whole Foods. I try to eat healthy. That's obviously a well balanced and an organic diet. I think that's a general recommendation for all patients. Avoiding red meat, trying to be low on soy and other estrogen-like substances containing foods. I always see like echinacea sold out. It's like you see the entire supplement aisle and echinacea has been sold out. There have been quite a bit of observational studies looking into these immune boosters, looking into zinc, looking into high-dose vitamin C, and they don't seem to be really doing much in the setting of COVID. But again, there's still a learning curve, but I wouldn't recommend going out and endorsing any specific supplements. There's just not enough that we know. But in general terms, it seems like that the most severe cases of COVID happen in patients that are actually fully immunocompetent and not necessarily patients that have a compromised immune system. The exception here are lung cancer patients, and there's the factor that they are both on immunosuppressive therapies with chemo, plus having a pre-damaged and frequently inflammatory background in the lungs, which is typically not the case for most breast cancer patients. So I would say avoidance of viral exposure is currently the cornerstone of your best path forward until we know more.
In other words, stay home and stay safe is the best advice that you have.
Right.
So last question, doctor. So, research is key, clinical trials. We know that someday, hopefully, we'll find a cure not only for breast cancer, but for
Right.
MBC. Are there any, advancements in treatment, advancements in research? Is there anything that those that are currently, have MBC can look forward to?
Right. Well, I mean, 2020 so far was from a cancer advancement standpoint was a great year. We'll talk a little bit about the HER2 positive space, and then also about the triple negative space. I think they're both very important. HER2 positive disease used to be the high expression of the HER2 receptor on the surface cells. There were basically a quantification by microscopy that looked at these levels, and we have two new mechanisms, and we know this is kind of an initiating event that kind of maintains throughout the entire course of HER2 positive disease, and having the ability to target this with new drugs that are not immunosuppressing is tremendously helpful. There are new drugs that have been utilized. Tucatinib is one of them. There's actually a pill medication that works anywhere in the body, including the brain. So it's a very transmissible kind of medication that reaches all compartments of the body. It's been shown to extend life, and it's actually very feasible with a very good quality of life. There's another drug called trastuzumab deruxtecan. Is a little bit of a Trojan horse. So it is based on the antibody Herceptin, which has been the backbone of HER2 treatment for the last 20 years. But it has a new feature. It basically is coupled to a very potent chemotherapy molecule. So it delivers, it basically the antibody finds like a homing beacon the HER2 positive breast cancer cell. It gets taken into the breast cancer cell through the HER2 receptor, and then cleaved so that the chemotherapy that is attached to the antibody can release its local effects. So it's kind of a very targeted form of delivery of a very, very potent chemotherapy agent. The typical patients that receives the therapy extends life by about 18 months to a year and a half, and this was tested in a later line setting. So this is a dramatic progress that has been actually approved between the holidays at the end of last year, that has been available. And it's also defining a new category of HER2 positivity, which is called the HER2 low. So we basically the pathologist under the microscope defines this as HER2 strongly expressed, moderately expressed, or low expressed. And so far we've only used HER2 expression for the high category. This has changed. So we have very good data now that suggests that even for the HER2 low expressing breast cancer cells, this antibody attracts strongly enough to actually be able to deliver the chemotherapy right into the tumor where it's supposed to exert its effect. I think that's the second one. The third one is we have rituximab, which is the I want to say the updated version of Herceptin or trastuzumab. It's a little bit effective in a later line setting. So this certainly is going to add to that armamentarium. And we had an approval also for neratinib for the metastatic breast cancer space. So this is 3 to 4 new options in the course over the last 6 months that have been found to add to the quality of life and the length of life of HER2 positive breast cancer patients. The additional last approval, and this was major breakthrough, was sacituzumab govitecan. It's a very similar concept between an antibody that guides into the triple negative breast cancer cell and a chemotherapy attached payload that basically then exerting the Can you hear me? You look like you're having difficulty hearing me. Okay, so let me go back to the triple negative. The problem with triple negative was just to summarize the HER2, we have basically 4 new therapies in the last 6 months for HER2 positive breast cancer. For triple negative breast cancer, we just had the first approval that actually came through. It's called sacituzumab govitecan. It's a very similar concept where an antibody is coupled to chemotherapy and delivers directly into the cancer cells. And the issue with triple negative breast cancer always was that we defined it by what it's not. It's not like the other two. It's not hormone receptor positive. It's not HER2 positive. So we kind of defined it as a negative. Now we have sacituzumab, which targets one of the surface molecules of triple negative breast cancer quite efficiently, and it's actually able to define that space. And then the third aspect of this is the molecular targeting. We have a lot more understanding of the biology underlying the disease now, and I'm a geneticist by training. I trained as a geneticist and then kind of extended this as a clinical interest into oncology, because in the end, oncology is an illness resulting from changes in genes, whether acquired or hereditary, most of them acquired. And to understand this is very helpful. We have a lot of approvals now by the FDA that are not specific for breast cancer, but are specific for genetic changes. And I would encourage anyone who has a metastatic or severe form of breast cancer to have that checked, to have looked into. I can give you a couple of examples that you know, BRCA1 and BRCA2. We have 2 medications that are approved for them, but those are only the beginning. We have very similar mutations to BRCA in the BRCA pathway that may be benefiting from targeting through the same agents, whether it's olaparib or talazoparib. We have NTRK 1, 2, and 3 that is FDA approved for breast cancer. In fact, I have my first triple negative breast cancer patient on an NTRK targeting medication, and it's a complete game changer. If you understand what you're actually treating on a deep molecular level, the plan of care really changes. It's like finding the right key to the right lock. You all of a sudden have a better efficacy profile and a better side effect profile because you actually know what you're doing. Yesterday we had an approval for pembrolizumab, which is one of the immunotherapy agents for cancers that have a high level of mutations in a cancer cell. We have these pan-cancer markers now really extending broadly. So in my opinion, every patient beyond the hormone receptors and HER2 should have an extended molecular panel or genetic panel to complement the understanding of their cancer. I know that the traditionalists will say ER, PR, and HER2, or estrogen receptor, progesterone receptor, and HER2 are what defines the disease. It has gotten so much broader, so much more complex, and so much more precise in terms of targeting that is certainly a stone that shouldn't be left unturned. If it is available, and typically with breast cancer, we do have tumor tissue that we can send to the laboratory for sequencing. There's very little harm in doing it. There's tremendous opportunity in doing it to answer, and there will be more and more information coming through for patients and opportunities for treatment. Those are treatments that are approved, but those are also treatments that are sometimes in clinical trial development where an access would be very feasibly done. When you live in Florida, you have in every corner of the state, you have great research and academic facilities that are able to provide the next frontier of cancer treatments to patients. You have the University of Florida in Gainesville, you have the Sarah Cannon Research Institutes here in Orlando, or you have the Tampa Cancer Center in Moffitt, you have the University of Miami. So there's plenty of access to novel therapies. I know that they're currently on hold, but in order to find your way for the most appropriate treatment, I think these next generation sequencing or molecular tests should be really done on every metastatic breast cancer patient. Now, there's so many reasons to do it that it's something, if it hasn't been done, it should be discussed with your medical oncologist as a way of testing. The tissue is already in the laboratory from the previous biopsy to confirm the diagnosis. So it's just a matter of filling out the paperwork and sending it off. So in summary, I talk a lot, I know that. It's plenty of new opportunities and accelerating progress because we understand much better what breast cancer actually is beyond the site of organ origin. but really understanding the underlying biological and molecular drivers and being able to utilize them for benefit, for more effective and less toxic treatment. Well, I think my message is don't fret. I think this will pass. I think there will be a vaccine. I've never seen a concerted effort like this in development, and this is across governments, across private initiatives. We call this the Manhattan Project of pharma, and there will be a vaccine, so there will be a time after COVID. I can't tell you that it's going to be October, January, or next July. And my positive message is that there is an end, that the processes and the opportunities are going to be coming back, and they're going to be working out again in your favor. That in the meantime, you need to do what you can to make sure that you stay safe and sound, and keep those safe and sound around you as well. To make sure that you can get the best treatment, get best access, take good care of yourself, be forgiving if you're struggling with this. I don't know anybody who is not, and I think Josh and I are no exceptions to that. I think we all have our worries and concerns and changes, and it is a crazy time we're living in. And I do see the light at the end of the tunnel. And if you're a metastatic cancer patient, you fought through difficult times and difficult moments, and you kept your eyes towards the end of the tunnel where that bright light is coming up. And in my scientific assessment, I would like to say this light is getting brighter and it's coming closer. Hopefully sooner rather than later, but it's not going to be forever, and it's not going to change the way we should look at the future.
Well, thank you so much, Dr. Dietrich. We really appreciate your time today. And for more information,
absolutely,
please tune in, and we'll see you again on a future segment. Thank you so much.